Hello everyone, and welcome to our presentation on neonatal hyperbilirubinemia. My name is Dr. Karthik Iyer, and I'm going to be your guide and presenter for today. And I want you to consider me as an enzyme that digests this complicated material and breaks it down and gives you small bites for you to process and understand. So by the end of this presentation, you should be an expert on neonatal hyperbilirubinemia for the Step 2 CK exam. You might be able to pursue your PhD afterward too. Alright, let's get started. So we have a practice question here to prime your brain to digest all this information that we'll be encountering as we go along. Just like a lawnmower, you need to prime a couple times before you pull the trigger. Same thing, we're going to prime your brain. You guys may be a little too young for those kind of lawnmowers though, but those are my day. What is the next best step in management for this patient? So we always read the question first to identify what we're looking for and what the question is asking. So immediate phototherapy, immediate exchange transfusion, stop breastfeeding and replace with formula, test for levels of UDP glucuronidyltransferase, or reassurance. So we know there's something going on with bilirubin here. All these options involve bilirubin, and we need to figure out what the question's asking so it can help us. So always we want to highlight next best step in management. So we're worried about what we do next. That's a very common theme for Step 2 CK. So a 5-day-old male neonate, so a young male neonate, recently born, is born at term to a 25-year-old woman and starts developing a progressive yellow discoloration of his skin and eyes down to his toes. He's turning yellow, the theme of our presentation. Infant is being currently breastfed. So we have a progressive yellow discoloration all the way down to his toes. So it's pretty severe discoloration here. Mother attended all prenatal screenings and L&D was uncomplicated. L&D meaning labor and delivery, so the mom's been good. She's been going to all her screenings and taking care of herself and the baby. Excellent. Family history is remarkable for mother's younger brother dying shortly after birth due to similar yellow skin. This is big. We've got a family history of a death after birth from something similar to this yellow skin. So we have to be worried about something possibly genetic and lethal here. Vital signs are stable and physical exam is within normal limits. The resident physician orders a bilirubin panel. We got a smart resident here ordering this bilirubin. Total bilirubin is 26 milligrams per deciliter. Unconjugated bilirubin is 25.9 milligrams per deciliter. And conjugated bilirubin is 0.1 milligrams per deciliter. So we know that the unconjugated bilirubin is very high. So why is having unconjugated bilirubin so high a problem? I want you to think about this. Correct, because of kernicterus. So I want you to imagine unconjugated bilirubin as a spy that can invade any part of your body, including the blood-brain barrier. So the unconjugated bilirubin, being fat-soluble, can sneak into the blood-brain barrier and deposit all over the place in the fetal brain, and this can lead to neurologic deficits and lots of major problems, and that's called kernicterus. So we also notice that phenobarbital has no effect on unconjugated bilirubin levels. Why would we give phenobarbital to a baby? Are we trying to sedate them? So phenobarbital, the purpose is it's a CYP450 inducer. Alright, you'll also notice that phenobarbital can also be involved with acute intermittent porphyria, which we'll talk about in a different day. But since it's a CYP450 inducer, it can activate the UDP glucuronidyltransferase enzyme and upregulate the amount of conjugation taking place. So remember, when bilirubin is unconjugated, it can sneak by the blood-brain barrier. But if bilirubin is conjugated, the brain can say, hey, you're not coming in. So phenobarbital having no effect on unconjugated bilirubin means that there's some problem with UDP glucuronidyltransferase. Okay? So let's start with the answers now. We'll hold on to A and B because A and B are the very common answers associated with high bilirubin levels. Let's go to C. Stop breastfeeding and replace with formula. So we have a severe problem here possibly. We have a very high unconjugated bilirubin. A normal level is for a physiologic jaundice is around 10 to 12. So it's over double that. And we also have a family history of death early on. Would it be a good idea to stop breastfeeding and replace with formula? If you were dying and had a severe condition, you were scared and had family history of death, you'd probably be pretty angry if your doctor told you to just go home and drink some formula. So this is not going to be it. Alright, breastfeeding can worsen hyperbilirubinemia because breastfeeding breast milk has beta-glucuronidase and can deconjugate bilirubin in the GI tract. But this is not going to be involved here because the bilirubin is way too high. Alright, next let's look for test for levels of UDP glucuronidyltransferase. This patient is having an active major problem And this unconjugated bilirubin could kill him because remember we talked about the sneaking into the brain kernicterus. So we would have a really terrible resident if they ordered a lab instead of treating the problem. So let's get rid of that answer. Next one, reassurance. How would you feel if your doctor told you, hey, it's all good, go home, when you have a severe condition? You probably wouldn't be very happy about that. So reassurance is not the answer here either because we have a severe condition that we're worried about. However, you should know that reassurance is a very common answer with benign conditions. We'll talk about that in testing strategy. Now we have immediate phototherapy and immediate exchange transfusion. So phototherapy is for milder hyperbilirubinemia, and exchange transfusion is for very severe hyperbilirubinemia. So phototherapy is usually for bilirubin above 18 and less than 25, and if a patient is not having major symptoms. So when we look at the bilirubin level here, it's greater than 25, but the patient's also not having symptoms, but this level of bilirubin is very, very scary for kernicterus. So we're not going to have phototherapy here. Immediate exchange transfusion is the answer because of the high level of bilirubin and because this patient may have Crigler-Najjar. We cannot identify that 100% until we do a genetic test, but because of the risk of Crigler-Najjar, family history of death early on, and the high bilirubin levels, this is an emergency, and we have to give exchange transfusion to treat our patient and protect the brain from kernicterus. All right, let's move on. So now we're going to have an overview of hyperbilirubinemia. Now you're going to get a lot of information in these slides, and I'm only going to highlight the major important information because going over every little detail will not be efficient for you and for your time. So read these slides and get all the information for yourself, and I will hit the high yield points and make them interesting so you can handle them. So we got a whole jaundice family over here, the Simpsons. Do you ever realize that they were just jaundiced the whole time? So this whole family needs treatment in more ways than one, psychological and physical. So let's talk about jaundice. Jaundice is yellow skin and eyes, like our friend Homer here. So due to hyperbilirubinemia, we have sclera affected, face affected, and as bilirubin levels increase, the jaundice descends. So as you have more and more bilirubin, the jaundice goes down the body further and further. This is just information for you to know. You don't need to memorize these numbers. Just know sclera is affected first, and as you go farther and farther down the body, the worse the hyperbilirubinemia is. Now let's talk about risk factors for hyperbilirubinemia severity. We need to see what's the worst situation because we want to know when the patient has the highest risk for kernicterus. So I want you to think of a very yellow, very young, very premature, and very sick baby. All right? I know it's not a very pleasant thought, but you have a very young because the number of hours after birth is very important. If it's a very young baby, like first couple hours it gets jaundice, that means that the baby is at a high risk. Within the first 24 hours, jaundice is usually pathologic. So the earlier the jaundice, the worse it is. Gestational age upon delivery, the more premature the baby is, the worse the outcome. Because remember, prematurity means the UDP glucuronidyltransferase is not mature. So if it's not mature, it's not going to be converting unconjugated bilirubin to conjugated bilirubin, and you have a higher risk of kernicterus. The third is having a very sick, weak baby, because the more symptoms you have, the more likely the kernicterus is actually happening, and the unconjugated bilirubin is causing problems. So unpleasant thoughts are usually easiest to remember. So remember a very young, very sick, very yellow, all throughout its body, and a very premature baby. And that is what will tell you that you have the most severe case of hyperbilirubinemia. And as you have a more sick baby and having more of these symptoms, the lower the threshold for phototherapy and exchange transfusion, which are the treatments for this condition, which we'll talk about later. So number of hours after birth, gestational age, and symptoms and overall health. So kernicterus, we've already talked about this. We won't go into too much more detail. Kernicterus is when you have the lipid-soluble unconjugated bilirubin crossing the blood-brain barrier and depositing on the basal ganglia and brainstem. So we know the basal ganglia is important for motor function and coordinating with the cerebral cortex for motor movement. So what would happen if the basal ganglia get deposited with unconjugated bilirubin? Lots of neurologic symptoms involving tone, spasms, and cerebral palsy, all right, and poor feeding. So the hypertonia-hypotonia is because the basal ganglia and cerebral cortex are getting damaged, and you have problems with muscle tone because the basal ganglia can no longer regulate muscle tone. Opisthotonus or back spasms, same reason. If you have hypertonic back muscles, they'll spasm. High-pitched cry and fever. The reason for these is because of fetal distress or infant distress. Athetoid cerebral palsy because you have problems with motor coordination. And remember, When you have Huntington, that's a problem with your basal ganglia, you get those writhing snake-like movements. So you can get those same movements here, all right? And we also have lethargy, poor feeding, and seizures because the brain is being damaged. So that's why all these symptoms occur. Whenever you go through symptoms, you should always understand why they are all occurring and not memorize them. Memorizing will never get you anywhere with symptoms because there's so many. You want to understand the pathophysiology and the background behind them, and that's what I'll help you with. Next thing is that bilirubin binds to albumin in the blood. So low albumins mean you can get higher risk of kernicterus. So liver damage, prematurity, these things can cause low albumin levels and predispose to kernicterus. So now, our favorite thing, drugs, pharmacology, the most fascinating topic that frustrates students worldwide. We need to talk about how these can be used in neonates and how they can be dangerous in neonates. So remember, we talked about albumin being important for bilirubin metabolism and carriage. So if you displace bilirubin from albumin using one of these drugs, guess what's going to happen? Hyperbilirubinemia. You get that sick jaundice kid. So sulfa drugs, ceftriaxone, aspirin, and hydrogen ions, okay? Sulfa drugs are very, very commonly associated with drug interactions because they bind to albumin and are carried around by albumin. So that's going to displace bilirubin, unconjugated, and that's going to cross the blood-brain barrier and cause problems. So sulfa drugs need to be watched out for in neonates. Ceftriaxone has two causes. One is that it dehydrates the bile and also causes excessive bile crystallization, leading to bile sludging, and that'll cause decreased flow of bile and backup into the liver, and that'll cause decreased function of the UDP glucuronidyltransferase. Okay? And in addition, it's also going to get rid of the bilirubin from albumin, and these combination effects cause very high levels of bilirubin unconjugated in the blood, increasing the risk for kernicterus. So if you ever see a patient with sepsis or any kind of bacterial infection, avoid ceftriaxone. I know it's one of our favorite drugs for adults, but kids do not like ceftriaxone. Think of a very angry kid if you give him ceftriaxone. Aspirin, acetylsalicylic acid. This has to do with acid, so we'll talk about that in the hydrogen ions. We have sepsis and acidosis. Remember from physiology that H plus can bind to albumin and knock off oxygen in the Bohr effect. So this hydrogen is going to be very attracted to the negative protein albumin charges, and that's going to knock off bilirubin and increase the risk of hyperbilirubinemia and unconjugated kernicterus. So why does sepsis cause acidosis? Take a second and think about this. So sepsis and septic shock are going to damage tissues and decrease perfusion to tissues. And what's going to happen there? You damage the tissues, damage the electron transport chain, and now how are you going to get all the electrons out of the NADH? You're going to have to use lactic acidosis, lactate dehydrogenase, which converts pyruvate to lactate and releases the NAD+, so you can regenerate it for glycolysis. I know this brings you back to the terrible days of biochem, but it's very important to know when you damage tissues or hypoperfused tissues, the default pathway is the lactate dehydrogenase pathway to regenerate NAD+ to continue glycolysis. You'll get an excess of lactic acid. All right, so these are all the important things about hyperbilirubinemia. Now we have another practice question, antibiotics. So we were just talking about antibiotics, so now is our chance to go over it. So remember, the first thing we always do is we read the question so we know what's going on. Which of the following antibiotics is appropriate to administer in this infant for his condition? So we want to know which of the following antibiotics is appropriate to administer. Okay, and remember, this is an infant, so some antibiotics may not be safe. IV levofloxacin, IV doxycycline, oral Vanc, IV Bactrim, or IV ampicillin. So we have some options here. Now let's get to the question. A 12-year-old male infant is brought to the ER by ambulance after developing jaundice of his eyes and face over the past hour. He's also irritable and feverish. So things we want to highlight, remember, always highlight questions so you know what you're looking at. 12-hour-old male infants develop jaundice of the eyes and face over the past hours. Remember, we talked about earlier that having jaundice of the eyes and face means that it's not too high levels yet. He's also irritable and feverish. All right, he's born at home by spontaneous vaginal delivery, so that's not good. This mom gave birth at home, no medical treatment, no OBGYN doctor. That could be scary and could be problematic. Breastfeeding is poor and infants crying loudly. Vitals are 95, 200, 48, and 68/38. So you should know a general idea of what temperature should be like in an infant. So usually the temperature should be around 97, not quite 98.6. Heart rate should be around 160, maybe less. Respiratory rate should be less than 40, and blood pressure should be about 80/50, greater than 80/50, 8/60. So these vitals, you have a low temperature, high heart rate, high respiratory rate, and low blood pressure. So this is not good. We have a very, very sick infant here. And remember we talked about sick infants. Those are very likely to have problems and higher risk of kernicterus. So resident physicians suspect the infant has developed sepsis from a delivery. Wow, we have a pretty intelligent resident physician here coming up with the diagnosis immediately. Bilirubin panel is ordered and confirms the presence of a mixed hyperbilirubinemia. Okay, so it's mixed. That means you have conjugated and unconjugated bilirubin, and blood cultures go beta hemolytic, gram-positive cocci in chains. We got some bacteria here. And look at our beta hemolytic, gram-positive cocci. See those chains here? This is very important to remember, and it's purple colored, so the gram stain is positive. So now let's go into the question. Which antibiotics are appropriate to administer to this infant? So we know that the patient's got a gram-positive infection, but we also know that certain medications aren't good for kids. So let's go through them. IV levofloxacin. Would you want to give a kid as fluoroquinolone when they are early on in life? Absolutely not. Think of a very angry, unhappy kid if you put a pill of fluoroquinolone or an IV dose of fluoroquinolone anywhere near him or her. Remember, that causes tendon rupture and cartilage damage, so angry infants, not wanted. IV doxycycline, another thing that will make the infant very mad. What does that cause? Correct. It causes bone damage and teeth staining. Do you want that kid to go to his dentist all the time because you stained his teeth? I don't think so. Next is oral vancomycin. Do you want to give an oral vancomycin for an infant? They don't probably barely can swallow breast milk. How are they going to swallow a medication? And in addition, oral vancomycin does not have enough bioavailability to target a gram-positive cocci that is septic throughout the blood. So whenever you have sepsis or a severe condition inpatient, you should give IV medications and avoid oral ones. Now IV trimethoprim sulfametazole. See that word sulfa here? Key point. What do we say about sulfa? Angry infant, not happy, they don't want this. And that's going to cause increased risk of kernicterus. They already have a mixed hyperbilirubinemia, that'll just make it worse. And now IV ampicillin. Ampicillin is a penicillin that can be used against gram-positives. There are no known effects for infants. It's pretty safe. And this will treat the problem, and that'll be our answer here, okay? So the answer for this one will be E, IV ampicillin. Very good. Now this is a rapid recall memory slide. So for the last 4 slides, I've taught you a lot of information, and the best way to register it in your memory is to write all down whatever you remember. So without looking at the stuff you looked at before, write down everything you remember from the stuff I've taught you, and then we will come to the next presentation and move on from there. See you then.